Thanks, Michael. It's great to be back with all of you this morning in the Motor City. I wanted to give also a special thanks as well to the Detroit Regional Chamber for bringing us all together at this Healthcare Leaders Forum, and in particular to Ed Wolking and Hank Looney for their leadership of the Chamber's efforts in healthcare areas, which are increasingly critical. We're going to be hearing from Governor Snyder in a few minutes, as well as business leaders, healthcare leaders, other government leaders, patient advocates, many people today about the critical issues facing our nation and Michigan in particular. And I do want to highlight the leadership that is taking place here. I'm going to do this a bit in my remarks, but just looking around the rooms, I know we've got health plans that are undertaking leading efforts like Blue Cross Blue Shield of Michigan in finding better ways to pay for health care, organizations like Arbor Metrics that are doing healthcare analytics to help make smarter decisions about surgeries and other major procedures, healthcare value purchasing done collaboratively here in Southeast Michigan, and of course healthcare delivery leadership at places like Ford and the University of Michigan. So you couldn't have a stronger group coming together to deal with the problems today. And you know what, I actually think I left my, yeah, there we go, I left my slide advancer over at the table. I can still keep talking indefinitely. I come from 4 generations of very fast-talking Texans, so the slides are a bit incidental, but it'll try to keep me a little bit focused as we go through a big set of issues. So I was talking with Ed about the conference beforehand, and asked, well, what kinds of things you wanted me to cover, and I was writing on this list. It's pretty much everything on healthcare reform and whatnot that we're all facing together. So I think what I'm going to do is try and touch on a number of issues that will be covered in more depth, or may be covered in more depth in the rest of your from the rest of your speakers this morning. It's going to start out with the Affordable Care Act and where we're headed beyond the Affordable Care Act with upcoming events like the King versus Burwell decision in the 2016 election. Then I want to talk about some of the fundamentals that, it's easy to get caught up in the politics, and these policy decisions in Washington do matter, but there's some other forces that I think are really important that are going to shape where our health policies go rather than the other way around. And those are things like the changing nature of medical technology and the movement from treating health problems towards more precision medicine that's focused on individualized care that prevents those problems in the first place. And that leads to some of the policies that I do want to focus on. Things that I'll call accountable care reforms. I'm not sure that's the best name for it, but the idea is shifting the way that financing works in healthcare away from paying for stuff, from the volume and intensity of services, to having payments that are at least tied in part to what it is that we really want. So that's more direct alignment between where the resources are going and the reasons that doctors and other clinicians got into healthcare in the first place, the reasons that patients are so concerned about decisions for themselves and families are so concerned about decisions for their loved one, and that's better, longer, healthier lives. So that's what I'm going to try to cover today and set up some of the discussions that are going to follow a little bit later this morning. First, just start with the Affordable Care Act where we were. So as you all know, the Affordable Care Act in many ways was about coverage. It wasn't only about coverage, but that's where most of the money is going and where most of the revenues raised through things like reducing Medicare payment rates went into. And as you all know, there are 2 major components, the Medicaid and the Medicaid expansions that have occurred in many states, thanks to the previous Supreme Court decision, not all of them. I did want to highlight then even states that didn't expand Medicaid coverage have had significant increases in Medicaid enrollment, whether it's a woodwork effect, people who have heard about everything going on with the ACA and signed up or otherwise. It's been fairly substantial, especially in the Deep South. You can see the percentages of eligible beneficiaries there in the darker color means more take-up, significant activity here in Michigan. Also, some changes in the way that these Medicaid expansions are occurring. This is particularly true in you might call the purple-ish states. Iowa and Arkansas has gotten a lot of press for this, and a few others, in that they've been moving more in the direction of competing private plans delivering Medicaid benefits, and that's true in many other states as well, including here. So moving away from traditional ways of government-delivered benefits in the Medicaid program to competing private plans. Some states right now, like Indiana and others who've not yet fully expanded, are pushing on issues like individual responsibility through things like sticks, like paying more if you go to the emergency room, carrots like giving people health accounts if they take steps to work with a primary care provider, adhere to their medications or otherwise, and even time limits under consideration, some waivers for able-bodied adults staying on Medicaid. I think we're going to continue to see these evolve over the next year in the administration. Probably not a lot of movement of more states adopting Medicaid coverage expansions, but the program is definitely evolving. And then obviously the big component of the law was the setup of the exchanges in the states. Most of the states, all but 16 in the District of Columbia, are relying on the federal government in whole for the most part, in part in some states. And many of those states have had significant expansions in coverage. Interestingly, about half of the people who are eligible for coverage under the ACA have enrolled nationwide, maybe a little bit less than half. But most of the enrollees have been people who had significant subsidies for insurance purchase. So the typical cost for premiums for people who are in ACA plans is well under $100 a month because of the subsidies. And again, these numbers are increasing. So if you put that all together, in most states, including states that did not expand Medicaid, there have been some significant reductions in the rates of the uninsured, which was probably the number one intent of the Affordable Care Act, to give people access to, in the President's words, meaningful health insurance plan, and to do so while addressing issues like insurance underwriting and problems with people getting continuity of coverage. But would highlight that although there has been a lot of enrollment, there still is a significant number of uninsured Americans. There are still real concerns about the cost and access to care within the plans that people have signed up for. I'm going to come back to that a little bit later. And like all major issues in American politics, which really matter to people and where philosophical views differ, this one is certainly not settled. So more coming. I think this year, this month, look for some more attention around penalty enforcement, so people finding out, maybe they didn't focus before, that they really do owe something significant for not taking up coverage. Also, a lot of cases where, because of unexpected changes in income, both upwards and downwards, people are finding when they pay their taxes that they either owe additional amounts or might get a bit more money back. I think they're turning out to be more in the former category than the latter. And these are just playing out for the first time right now. So there have been some bumps earlier in the implementation of the ACA, probably some more to come over the next few months as these issues around the penalty implementation get going, and over the next few years as the size of the penalties for not having coverage really start to ramp up. And of course, what everybody in Washington likes to talk about endlessly right now is the King versus Burwell process and decision. And this is one of those where, just different sides see this different ways. If I was just going to do a very brief summary, and I know many of you have probably already spent some time reading about this issue and have some views on it, I think overwhelmingly the legislative history suggests that what the drafters of the law meant to do was make subsidies available everywhere. If you pass restrictions on insurance underwriting and minimum benefit requirements and things like that, like the law clearly does in every state, and don't do something to provide subsidies, it is going to really destroy the individual insurance markets because only sicker people will sign up. And if you look at a lot of the discussion motion on the floor and so forth. It kind of goes along with that point. On the other hand, if you're arguing the other side, you can definitely point to some people at various times who have said something to the effect that that could be a real stick for states to adopt the law. I just don't think that's kind of the dominant take from the discussion around the implementation of the law. The problem is that's not what the law actually says in these key places. The law does specifically refer to exchanges established by the states. So you then have to go into these motions to try to get an interpretation around that, well, you should look at the overall context and so forth. And this is the kind of thing that I think resulted directly from the complications of passing a law as big as this one through a reconciliation process without conference. That's when you catch these sorts of problems, these sorts of drafting errors. There's always a manager's amendment that goes on and it's incorporated through the conference process to clean up all these kinds of things. I think really an interesting question from the court standpoint, if they do end up seeing it sort of the way that I just described, what do you do? I don't know what the Supreme Court does if there's like a meaningful drafting error like this one. All that said, most people think that the law is not going to be, that the subsidies are not going to be overturned in the state established exchange states by the Supreme Court. If it does happen, I think you can expect to see some of the same kind of pressures for last-minute pressures on both sides. Very different views about this issue, finding some way to perhaps come together at the end. The court had some discussion this spring about having a delay period before its ruling went into effect to give Congress a chance to act. If there is such a period, my guess is that Congress still won't act till the last second. This is one where the views are just very different, and the administration's position is going to be that there's a simple solution for this, which is pass a simple change in the law that corrects the language. The Republicans are trying to come together behind an alternative. It's hard to put a whole new structure in place in the short term on an interim basis, like turning over the funds to the states or something like that. But they will, I expect, come together behind something, and then you may get sort of a series of short-term actions. Well, we couldn't quite work it out this time, so we'll do a 3-month extension or a 6-month extension, maybe continue this through 2017. But even if the Supreme Court upholds the law, one of the things that this continued political process has done is just remind people how different Americans feel philosophically about the role of federal government. This is absolutely going to be a live issue for the 2017 election and for the 2016 election, and therefore the 2017 new administration. If there is as expected, the Republicans retain control of the House in 2016, and maybe with a tighter margin retain control of the Senate. And if they are able to elect a Republican president, one of that president's top priorities will be some version of repeal and replace. One version that you might look at that's appealed to many relatively moderate Republicans is a bill sponsored by Senator Burr and Senator Hatch, among others, that in key features differs from the current law. It'd be a much more flexible approach to Medicaid. It would be use of subsidies to expand coverage in the private sector rather than through Medicaid programs. It would not have a mandate. It would give health plans more leeway in terms of how they design benefits, more use of flexible savings accounts, HSAs, and new coverage designs and things like that. It would not have an individual mandate for coverage. It would instead encourage people to stay in coverage through late enrollment penalties. You might say that won't work. Well, that's what Medicare does, and Part B and Part D, and works pretty well there. Maybe different in this population, but that's the direction they'd like to go. It'd be very difficult to get that through Congress, even if you have a majority, and even if you try to use reconciliation. Key provisions like modifying the provisions against underwriting don't really easily fit into the requirement of impact on federal budget directly that sequestration requires. So we might expect to see something come out in more in the middle, where there's less reliance on individual mandates, more flexibility for plans, more flexibility for states in doing what they'd like to do. Indeed, I think one of the more interesting things that a new administration on either side, but especially on the Republican side, could try in 2017 would be to use a different provision of the law, so-called Section 1332, is put in there by Senator Wyden, that gives states a lot of flexibility in designing care, designing coverage the way they'd like within a wide range of alternatives to the current ACA structures. They can modify benefits, they can modify mandates, they can modify other things, as long as they get comparable results. And you might say, well, it's going to be hard to get comparable results unless you do exactly the same thing. But for any of you who have worked on some of these healthcare issues in Washington, think Medicaid and Medicaid waivers, and I think this is going to fall in that category too. There's a lot of room for judgment in terms of what's exactly the same or what's comparable, and how you measure that. And it's not very well specified in the law. I understand a lot of people in the administration are thinking hard about this, and they're going to put their stamp on what they think the 2017 Wyden Section 1332 program should look like before they leave office, but that could be changed by a new administration. If I was advising a Republican candidate, I'd probably tell them to have one of their implementation groups working on getting that program ready to go right out the door in January 2017. After all, one of the main alternatives that Republicans have proposed in case King versus Burwell goes their way is to give states a lot more flexibility and some accountability for getting care improved and costs down, increasing access to needed health services. So there's a long way of saying there's a lot going on and will be a lot going on, and that the upcoming elections will matter because these are still very much not settled issues. I do want to point out one final issue here, though, right now. Who says there's no bipartisanship on healthcare in Washington? We are, I think, finally, for all the physicians in the room, going to be putting the so-called SGR, the sustainable growth rate, which has not been sustainable, behind us. House strongly passed bipartisan legislation to do this before its recess. The Senate didn't quite get there, but is planning to do it in April. You can always tell that CMS thinks that the government is close when they start holding claims from physicians, which they can do for a few weeks, so they can get paid the right amount when Congress goes back retroactively, fixes this, which I think they're going to do in a couple of weeks. But this highlights where there, I think, is opportunities for bipartisanship in Washington, despite some very fundamental differences about the role of government in setting mandates for coverage and mandates for what you have to buy and how big the subsidies provided by the federal government should be. What brought this bipartisan legislation together was a agreement that the current way of paying for physician services was not working. Major provision in this law is to move to alternative payment models. It includes a lot of bonuses for physicians who do that, 5% bonuses, some other payment-related incentives, and the like. It doesn't provide that much money into the traditional fee-for-service Medicare payment, so it's really going to be, I think, a significant push to something else. It also probably had an easier time passing because it didn't really define what that something else was. So there's a lot of discussion of alternative payment models in the legislation, but not really a whole lot of specificity about what that means. I'm going to spend a few minutes talking about that in just a minute. I think that's one of the big issues for the next few years in healthcare is that, okay, if we don't think that fee-for-service payments are really working well, what is the alternative? And is there a systematic way or more systematic way to figure out which of these alternative payment models really works, how to involve consumers and patients in them, and how to get them adopted more easily. Because right now, a lot of these alternative payment models and quality measures and things like that, I have to tell you, pretty frustrating for doctors, and the evidence of their impact it's been there, but it's been limited and mixed. So keeping it a bit vague, I think probably helped bring bipartisan support together. Also helping bring bipartisan support together was the fact that this measure was not fully paid for, but did include some reforms. So from the standpoint of having to make really tough votes to offset costs. This is a bit easier. What Congress has typically had to do is pass a short-term fix every year, and while it's easy to come up with the $20 billion you need to keep Medicare's physician payment rates from falling on a year-to-year basis, it gets very tiring for Congress to have to deal with that every year, and I think last year is just enough, a bipartisan agreement there between Pelosi and Boehner that we've got to do something else. There are some, I think, meaningful reforms in here, more income-related premiums for higher income Medicare beneficiaries, really just the top few percent, but that adds up. And some very limited reform in Medigap insurance, which doesn't exist anywhere else but in Medicare, is insurance that you can buy on top of the Medicare insurance to fill in all the things that Medicare doesn't pay for, which is a lot, and it's understandable why people want it, but it really does get in the way of what were intended to be financial incentives to encourage people to use care more efficiently. This takes a baby step in reforming that by prohibiting the Medicare deductible from being covered. This is about $140, $150 a year, and that's not trivial, but it doesn't really do much more than that to change the structure of what beneficiaries pay themselves. So those are steps towards reform, but not fundamental. And I think another thing that helped move this along was the extension of S-CHIP. And S-CHIP, in contrast to Medicaid, has much more bipartisan support. Why is that? Well, I think it started out that way as bipartisan legislation. You thank Senator Hatch on the Republican side for that, but also because of content. It gives states a good deal more flexibility than they have in the traditional Medicaid program and under the Medicaid rules. And this is a 1990 statute, not a 1960 statute, bipartisan one at that. It gives states a lot more flexibility in how they design the S-CHIP benefits, and it's worked pretty well and has supporters on both sides. I think if there is more opportunity for supporting coverage reforms for kids, maybe for low-income Americans around the S-CHIP kind of model, that could be a future area for bipartisanship as well. So that's a little bit of an overview of some of the things that I see have been happening, and I see happening over the next couple of years. And I'm sure there'll be a lot more views presented on these issues as we go on today. Now I want to switch gears and talk about the bigger picture of what's really going on in healthcare. And I have to start this. This is a chart that's a little bit hard to read, but basically the idea of this chart is for all the additional spending that's going into healthcare, every time we study it at a systematic population level, we seem to find that we're getting a lot for it. And this was from a summary done in 2007, so it's a little bit dated, but some of the more recent results along these lines are even more impressive. So just as a for example, for low birth weight infants, we now spend if you're low birth weight, it can cost upwards of $50,000, $100,000 a year to stabilize and keep an infant alive if they weigh under 2 pounds, on let's say 25 weeks or so. But we do it. And if you think about what that's worth, and I don't mean just from the standpoint of the parent of that child is worth like everything, you do anything for that child. But if you be like an economist, like my part-time economist hat on, and let's put a number on that. Say like okay, a kid's life in good health is worth $100,000 per year. All that money we spend up front turns out to be a very positive investment. And you can do the same kind of analysis for what's happened over the last 20, 30, 40 years for heart disease, where mortality rates have come down by 60%, costs of treatment have gone up, mortality rates have come down, quality of life has improved. Cancer, here shows about 1-to-1, that was in the 90s. That's gotten better through the result of further improvements in both effective treatments and in diagnostic capabilities. Overall, medical care combined, 3-to-1 return. Now, this is not saying, economists always make the distinction between average and marginal. This is not saying that all medical spending is worthwhile. No question, there's a lot that has very low value, and I'll talk more about that in a second, and some that is wasteful. On the other hand, taking it all together, it's been a pretty good deal. In fact, if you ask Americans what they, at least based on their revealed preference, what they care about most, their health and well-being and the health and well-being of their loved ones, or anything else, it's pretty much health. And I'll show you that again in just a second. And just keep in mind that one of the big drivers for this is healthcare technology. So everybody likes to talk about the cost savings, medical technologies, and I owe this chart to Peter Newman from Tufts. If you know him, he's done a lot of good work about what the contributions to different technologies have been. There are a few technologies that, if you look at the numbers, really have saved money while extending and improving lives. Vaccination of infants against chickenpox is an example, but for the most part, the technologies that have come along that have improved lives have come at a cost. So different things along the spectrum. I'll just highlight one. Sofosbuvir treatment for HCV, better known as Sovaldi, has gotten a lot of news in the past year for an initial price of $80,000 for what's largely, not always, but largely a cure for hepatitis C. This is obviously made a lot of attention, including yesterday in the news, Medicare talking about how they've spent, or CMS, my old agency, talking about they spent more than $6 billion in 2014 alone on these new hep C therapies, not just Sovaldi, but the others that have come along in the past year as well. That's a huge amount of money. But if you look at, again, those same kind of analyses that I've talked about before, it's been worth it. It's been worth it not because it saves money. It does save some money in terms of downstream medical costs. If you don't need a liver transplant, if you don't have the really unpleasant progression associated with cirrhosis, it's valuable and worth it because people live longer and better lives, and that's valuable and worth it in itself above and beyond the medical savings. So that's where you get a number here like $50,000 per quality. It's not cost savings. It's going to cost more, but more that by many reasonable people, again, people can differ, but many reasonable people would say, yeah, that's worthwhile. And that change in medical technology is really, I think, reflective of sort of the macro picture in healthcare. So I made a point about technologies getting better and continuing to get better. Been a big contributor in the past to rising costs of healthcare. This is a chart showing what your federal government does. It spends money on three things: Social Security, that's the dark blue area, healthcare entitlement programs, now including the subsidies on the exchanges and the recent Medicaid expansions and everything, and that's the red area, and everything else, that's the blue area. So there have been some ups and downs, and especially in that light blue part, those are all recessions. You can see the Great Recession of 2008 there. Federal government always spends more money on assistance programs and stimulus programs to help get us out of recessions. Take those out. There's really been one trend in this. So there's a demographic bit, which you can see with Social Security. That's gone from about 4% of GDP, that's GDP on the left side, in 1973 up to projected to be up at 5% by the time the baby boom retires. So people are living longer. There are more of them over 65, and we have an entitlement program created for their income support. But you can see the big story since since the modern post Medicare Medicaid era has been rising healthcare costs. That's the red section, and even with the recent slowdown and even stoppage in Medicare spending growth over the last couple of years, you can see that on the chart too. The expectation is that because of a combination of demographics, the program expansions like Medicaid and the ACA, and continued medical technology progress that again at least in the past, seem to be worthwhile on average, but is adding to costs. The healthcare spending, which has grown from around 1% of GDP in 1973 to about 6% of GDP today, is expected to be up another 3 or so percentage points of GDP in the next 20 years. This is really the story of the whole federal deficit. The reason we're having sequestration and debates about the budget at the federal level is because of these, because of the expected and continuing increases in overall healthcare costs. And it's why it's a central issue. And the main way that it seems to be playing out is partly in bigger deficits, but partly in that blue area getting steadily smaller over time. And again, that's everything else the federal government does. So that's low-income assistance programs, education program, infrastructure spending, research and development, going to Mars, whatever. It's all getting squeezed down. And what the public is telling you here, and this is explicitly written into the so-called sequestration law, which is further shrinking that light blue area, is that our spending priorities are sustaining Social Security and sustaining the nation's healthcare programs. That is what's most important, but it does have overall budgetary consequences. That's at the federal level. This is the state level. This is where state budgets are headed. Medicaid is now the biggest line item in most states' budgets, even the states that didn't expand Medicaid, and has been accounting for all of the increases in net increases in state budget expenditures over the last 5 years. Everything else, particularly education programs and infrastructure programs, have been cut. So there's some good intentions and some good results that have been associated with expansions of healthcare coverage and good results overall in terms of people living longer and better lives, but there are these major policy consequences as well. And so what I want to emphasize is, and hope to challenge this group to help address is finding ways to sort of have our cake and eat it too, right? Look, we're really on the cusp of an even greater era of discovery and development in healthcare. You heard the president talk about precision medicine. We're now developing gene therapies, drugs, other treatments that could potentially be curative or at least have a much more significant impact on diseases that were previously untreatable or poorly treatable. Cancer, Alzheimer's, all those are in there. Those drugs, I guarantee you, those treatments will not come cheap. They're hard to develop, and they are extremely valuable to the people who get them. So we're probably going to see some more effective treatments for unmet health needs coming along that, just like all the ones I showed you over the last 40 years, with very few exceptions, have been net cost increasing. Not that they haven't been worthwhile, they have added to healthcare costs. The thing that I want to emphasize is there seem to be today a growing number of opportunities as well to get costs down in healthcare at the same time. So think about innovations that are intended to better target these treatments to the patients who are most likely to benefit from them through better use of diagnostic technologies and the like, analytics and so forth. New approaches to care that have come to other industries but really have not made a huge dent yet in healthcare, like the use of wireless technologies and web-based personal health tools, which could replace office visits, could do much more cheap remote monitoring, early detection of problems, heading off of complications, new delivery sites, methods, better integrated provider teams, non-medical which are things like using nurse practitioners or pharmacists to assist with care management programs and adherence to medications in the particular patients who would benefit from those kinds of interventions, team-based approaches of care to help prevent readmissions, and new delivery sites like an acute care clinic in the neighborhood or at the office rather than having to wait and facing the added cost of going to a doctor. And obviously there are a lot of non-medical factors that can influence health, like everything from good education to having good wellness behaviors. The thing that I found most interesting when I got to CMS in 2004, I started over there sort of after the last big healthcare reform law had passed, the Medicare Modernization Act, and had been having a good time at FDA, relatively quiet and uncontroversial agency, and was asked to move to help with the implementation of the law. And so I was expecting to get there, and it's all going to be about Part D, and maybe talk about Part D for a few minutes in a minute as well. But what I found was that some of my most intense and heartfelt meetings and earliest meetings were with healthcare organizations, including some from here in Michigan, like the University of Michigan group, that was trying to do like all the things on this list. All these things that I wrote down here, they were like answering patients' emails, they were doing these, they were investing in readmission prevention programs and things like that. And we're pointing out, it had some results they could bring in and show me. They said, this stuff is really working. But, Mark, we're getting killed because Medicare doesn't pay for any of that stuff. It's all, everything that I just mentioned there on that list, the emails, the team-based care and things like that, those are not covered under traditional fee-for-service programs. So these organizations who were trying to do the right thing were facing two problems. One is they were losing money on their actual investments in these new innovative ways of delivering care and getting the right treatments, the right patients, the right time. And then on top of that, to the extent that this stuff really worked, they were having fewer hospitalizations, even fewer office visits, fewer lab tests, fewer duplicative imaging procedures, and so they're making less money on the stuff that Medicare does pay for. That's not a sustainable business model, and that can be a real source of frustration in healthcare. So the way I see it, and this is maybe an oversimplification, is we've got like two things going on in healthcare in the years ahead. They're not that different from the things that have been going on in the past. One is continued opportunities for innovation that's really going to improve people's lives and extend their lives. And again, it's been a great 20 or 30 years if you've been in cardiovascular disease or HIV or now Hep C. But I think the next 20 for many types of cancer, for other types of heart disease, perhaps for Alzheimer's and others, the next 20 may be even more impressive in terms of progress. Do not expect that to reduce healthcare costs. Just don't. It's not going to happen. What could reduce healthcare costs, though, is if we find better ways to use these new technologies effectively and make sure they're only used in patients who are really going to benefit. And that's everything else on this list. And we did some simulations of this. I'm going to go back to that it doesn't take much. I'm not going to go into the details here, but just the top part of the chart with the lines that go up, that's biomedical innovation, so that's the stuff that tends to cost money. We simulated things like, well, what if there was some treatment that came along that had a valuation for the entire population of 13 to 14-month life expectancy gain. We're going to let everybody live a year longer, and it's going to be gradually implemented in the U.S. population over 10 years. Even if the treatment costs are quite high, it's possible to offset those costs if there are fairly modest improvements in efficiency going on at the same time. In other words, if we can achieve productivity improvement rates that have occurred in many other industries steadily, these are on the order of 1.5%, 1.8% per year in terms of how we deliver existing care, how we use existing resources. That means things like using IT more effectively, emails, substituting sites of care, not relying on doctors when nurses can do the job, engaging patients more effectively. The list is really endless. If we can do those at the same time, you can offset those increased costs of valuable biomedical innovation. That's very different from, trying to support that is very different from what I would call the traditional approach to keeping costs down. Just, oh my gosh, healthcare costs are going up, prices are too high, and they are in many cases too high, and those should be addressed. I think there are better ways to do it, but as a comprehensive strategy, reducing prices, reducing access to care, it didn't work for that SGR program that I was just describing for physicians. Reducing access is probably not going to work in the ACA exchange plans that have very narrow networks done in a way that it makes patients frustrated. It didn't work in the 1990s with managed care. I think this other approach of better aligning our healthcare policies, mainly our financing, but regulatory policies as well, with the goal, not just with paying for more stuff, but with the goal of better outcomes and lower costs, is a better way to do it. I was going to talk about accountable care, which is I view as this move from paying for services towards paying for quality and cost at the person level, either for an episode, a set of services like a bundled payment for a bypass operation or a primary care medical home. That's a PMPM payment that a physician gets for providing a set of services and achieving a set of results in primary care for the patients that they take care of, or at the whole person level. So that's an accountable care organization is a good example of that. That's basically a more holistic payment tied to the overall results of care. I think some of you have heard about these, so I'm not going to spend too much time on them, but just starting out with accountable care organizations, these have been growing rapidly. I think the first ones that I know of were the ones that we created as a pilot program in Medicare after I had those meetings I was talking about earlier. It's like, why aren't you getting paid? So groups like University of Michigan joined the Physician Group Practice Demonstration, which we set up in 2005, which set up a second payment track in Medicare where instead of getting paid just based on the volume and intensity of services you provided, we started keeping track of the overall cost, not just the physician cost, but the overall cost of those Medicare beneficiaries that they cared for. They started keeping track for us of a set of performance measures, quality measures that we mutually agreed we cared about as a payer for this program and as the clinicians delivering it. These are things like diabetes control, cholesterol control, avoiding preventable readmissions, measures of patients' experience with care, things like that under traditional Medicare didn't matter at all for payment. And the deal was, if you could show improvements in overall performance in terms of quality and reductions in those overall cost trends, we'd pay you. You had to meet a threshold, so our actuaries didn't think it was occurring by chance. But if you did, you could get some significant additional payments. So it creates a sustainable, the idea was to create a sustainable business case, a financial case for delivering the care that these groups wanted to deliver to begin with. This was not the first time this has been done, but it's been done much more since then in the private sector and in the public sector. Medicare is now up to well over 400 ACOs, in the private sector over 300. We've been working with our ACO Learning Network at Brookings with now 19 states that are doing, and I think I should put Michigan on I'd like to put Michigan on this list too. They're not working with them yet, but 19 states that are implementing Medicaid versions of accountable care organizations. This is even more important here. It turns out that for a lot of lower income Americans, the biggest reasons for healthcare expenses are not things like, not things quite so simple as not adhering to your medication, but things like not having a home. Or not being in a substance abuse treatment program, or not having other social support. So some of these programs, these ACO programs, now they're moving away from just getting paid for traditional medical services. They're doing things like setting up community interventions and working more closely with targeted housing service provision because in some cases it turns out that paying for the housing supports is cheaper than paying for the repeat visits to the emergency room. There's another big NPR story on a program that's doing that in Minnesota this week. The results for these programs so far, I think, are good, but far from suggesting that we've succeeded yet. Medicare in its first year or two had something like 1 to 2% overall savings versus their benchmarks. They had impressive improvements in performance against the quality measures in the program, things like diabetes control and cholesterol control and the like that I mentioned. But a number of the organizations did not get any savings at all, and interestingly, some of the biggest savings came from some of the smallest ACOs. When people think of ACOs, they often think of these large integrated systems that's a group of hospitals and a large set of physicians. Actually, some of the groups that did best are ones that were smaller physician groups, may not even have a hospital affiliated with them, things that did like the Rio Grande Valley ACO in Texas, which took on downside financial risk too, and basically did just a few things. They got together to identify their highest risk patients. They pooled some advance money they were able to pull together into a tool that enabled them to get the actual useful information out of their very different electronic health record systems on what was going on with, say, all of their diabetes patients or all of their heart failure patients. And they started providing some more physician interventions and team-based interventions, so the highest risk patients got hospitalization rates down by more than 15% in the first year, and effectively had something like a 20% increase per physician in net revenues from that program. But it wasn't a big, high-tech, long-term set of steps. It was some very specific interventions that they undertook right away. On the commercial side, it's harder to get a comprehensive picture because not everybody publishes everything. But there were some very impressive results here in Michigan in a Blue Cross program, which is not exactly the same thing as this version of an ACO, but is this idea of moving payments away from being just fee-for-service to being tied to things like population health outcomes for primary care and specialty care providers, and Tom, maybe you'll talk about that a little bit later. And in Medicaid, some Results are pretty limited so far, but I think are impressive, or can be impressive for some of these very vulnerable populations that would really benefit from a non-traditional approach to healthcare delivery. I do want to emphasize that we're just starting out on this movement away from traditional fee-for-service payments towards alternative payment models, or I'd like to put like a more specific, clear definition on those. I think some of the most important dimensions to think about are how far you're moving away from fee-for-service. Most of what we've done in alternative payment models so far are just either add-on payments or things like shared savings, where the vast majority of the payments are still on a fee-for-service basis. There have been steps to move some of the payments, at least gradually over time, into more of a PM, more of a person-based approach that's tied to quality results. And I do think we've seen more impressive results in the organizations that have done that. Some of the most impressive early commercial ACOs, like in the Massachusetts Blue Cross plan, did that. Physicians and hospitals in that plan have a specific target of no greater growth than the overall economy. If they don't meet that in principle, they pay financial penalties. They got some money up front to offset some of their implementation costs that came out against those benchmarks later, and they've been able to deliver something like 2 to 3% savings per year cumulatively. Going back to my earlier chart, if we were able to do that throughout the healthcare system, I think we'd be in a much, much better position to afford the opportunities for improved medical technology that are coming along. So I just want to go on to one further point and then wrap up. And this is about how a lot of the emphasis on payment reform and alternative payment models has been on the provider side, but where I think really the untapped opportunities are, untapped, but partially tapped opportunities are, is on the consumer side. And I'd like to illustrate this with a couple of stories about my experience from implementing Part D. You can kind of read about if you want on the slide, some of the basic features of this program. This was a different benefit design. It's a different approach to benefits than in traditional Medicare, where instead of having the government come in and define a set of covered drugs or uncovered drugs or a price schedule or something like that, it's done through competing private plans. And we set some overall rules of the road, worked hard to try to implement that in a way that would be meaningful. When I talked to beneficiaries, and our staff talked to beneficiaries around the country in 2004 and 2005, we tried to ask them about everything that we thought they wanted to know about the Part D benefit. They kept coming back to us with one very clear and specific answer. I want to know what my drugs cost on my plan at my pharmacies. Okay, well, if we're going to do that, we have to transform the way that transparency works around prescription drug enrollment. Back before then, you all may not remember this, but if you wanted to know what your drug cost in your plan, you might be able to figure that out if you called up the plan. Probably couldn't figure it out very easily. We told all the plans if they were going to participate in Medicare Part D, they need to give us an up-to-date list every month of the price of every formulation of every drug at every pharmacy in the United States. So you can't do that. There are like 50,000 different drug formulations. We've got over 50,000 pharmacies. They're always changing their contracts. We don't have data systems in place. Okay, well, let's get them in place. And we spent a good 6-12 months doing that, building off some preliminary e-prescribing systems that have been in place with pharmacists, so that by the time Medicare Part D started, you could look up on our website, and it absolutely didn't work perfectly, but we worked through the bumps. You look up on our website the price of every drug formulation, every pharmacy for every plan, and if they weren't accurate, they got sanctioned. And that really made a huge difference. So when I went around the country talking about the Medicare Part D program, two things happened. One is seniors overwhelmingly told me how pissed off they were that the government couldn't just give them a damn drug benefit, that they had to they've got to choose among these like 30 or 40 different plans. Why isn't this as simple as the rest of Medicare? So we spent a lot of time trying to explain to them, and with a lot of help from groups that did not support the MMA because it did not take that approach to a single government-run benefit. I got a lot of help from those groups in helping people find, we didn't all agree about the law, but we all agreed that we wanted people to find out objective facts about what it meant for them. So we tried to take this from being a philosophical debate to a very concrete, practical debate about practical set of questions about what this means for you. And having that tool that enabled people to see exactly what their drugs cost at every pharmacy made it easy to do that. So people looked, they found that they could save a lot of money with their drugs, and they signed up. And interestingly, they signed up for plans that were not the traditional kind of benefit design. There's a standard benefit in the law which had a deductible, 25% coinsurance, catastrophic coverage on the back end, and that famous donut hole in the middle, because with the costs, people thought the costs were much higher than they turned out to be. Almost nobody is in that kind of drug plan today. What people overwhelmingly signed up for were tiered benefit designs where the most cost-effective drugs, the generic drugs, if they're available, are basically free. They cost like $1. And then for the under the requirements of the Medicare law, there had to be very broad coverage. But what plans would typically do is negotiate lower prices for drugs that were similar. So like for cholesterol-lowering drugs or non-sedating antihistamines or the oral drugs you take for blood sugar, they'd negotiate lower prices with a couple of them. Those would be like $30 a month. Pretty straightforward pricing because they had to tell seniors about it. And then if you want to take another drug, a non-preferred drug, a brand when a generic was available, you could take it. They'd be on the formulary, but you'd be paying a lot more of the difference. So under a traditional insurance plan, if Mrs. Smith went from a brand name drug for her blood pressure, like a beta blocker, to a generic, she might go from paying, say it costs like $90 a month, probably pretty typical. She might go from paying, 20-25% of that, say around $18 a month, to paying something like $5 or $6 a month. So that's $10, $12 in saving. That's something. Under these kinds of benefit designs, the ones that seniors overwhelmingly chose because they could see what they were getting. Under these kinds of benefit designs, Mrs. Smith's pricing payments would go from $90 for the brand name to like $2 for the generic. Well, you might expect the first thing that lots of Mrs. Smiths in 2006 did when they got on those plans was they switched from the brands to generics. They also switched from the non-preferred brands to the preferred brand name drugs to the point that now drug manufacturers really think twice before manufacturing and marketing a so-called Me Too drug. Or when they do come in, what happens is like what happened with Sovaldi this past year, which is the prices for both drugs come down significantly from where they would have been otherwise. And it's because it's kind of built into this design. So huge amount of complaining about the complexity of this and how confusing it was. Almost no complaining, very low rates of complaints about the switching under the formularies, and very high levels of satisfaction with this program today for being able to get the drugs that people needed. And from the government standpoint, very good results. So the red line is what the actuaries projected Part D would cost. The blue line is what it's actually cost. I'd like to think that clinicians had a big role to play in this and helping people shift the drugs that they were using to get more of the savings that have occurred here. And there are some other factors that contributed as well, but I think far and away the number one contributor to this program being much less expensive than it was while still meeting beneficiaries' needs is reflected in, so you can look at the beneficiary surveys. My ultimate test of whether your program is doing okay is what happens when the other party gets into power to that program. When the Medicare Modernization Act was passed, had a limited amount of Democratic support. In 2010, when the ACA went through, you all know what happened with Medicare Part D? Close the donut hole. No switch to government-run formulary, nothing else. Left that all alone. So that's when people aren't talking about it in Washington, that's when your program's kind of working. The costs have been much lower than expected. It's actually been pretty impressive. I know that Sovaldi's made a lot of news, and the Hep C drugs have made a lot of news in the past week. So Medicare spent over $4 billion on Hep C drugs in 2014. During that time period up through 2014, that's what happened to Part D annual per beneficiary growth. Went down, including in 2013 and 2014, not because there wasn't a lot more money going and spending on Sovaldi. It's because at the same time there's a lot less spending going on in other types of drugs. This is a good example of that. So everybody's talked about, and with understandably, you should be very concerned about the growth in total specialty drug spending, but that's happening at the same time as a lot of traditional drug spending has gone down. It's been driven by the kinds of changes that I've just described. So Part D previously was able to absorb Herceptin, Gleevec, treatments that cost billions as well, without having any real, premiums have been flat in this program for the last few years, without having increase in premiums, without having problems in access to care, because it's created this really strong pressure from the beneficiary side for accountable care. And so that's really what I wanted to end with, is that if you want a powerful force for healthcare reform, the provider payments are going to be really important. We're entering a new era. We don't really know what alternative payment models mean. Hopefully I provided some insights in where I think they should be going and the promise that they hold. But don't forget the opportunities on the consumer side to let them share in the savings, to let consumers share in the savings. If you give them information that they find compelling enough, they will act on it. I would totally agree that it's harder for things like hospital networks and joint operations and things like that, but I don't think it's impossible. And there's some good examples going on around the country that show that the same kind of approach that I've talked about with Part D could work for more beneficiary engagement in financing reform elsewhere. This may come to a point, just in back where we started on the ACA, around the so-called narrow network plans. These are turning out to be more common and more popular in the ACA so far, by narrow or ultra narrow, as McKinsey defined it here. These are systems that have only 2 or 3 hospitals and only a small minority of the providers in a region in those plans. Unfortunately, I don't think we have the kind of transparency around what you get in these plans that was easier in Medicare Part D, since it really, it wasn't easy, but it was easier to get drug pricing accurate than it is, and availability accurate than it is to do so for hospitals and physicians and other services. But I think really the biggest challenge for the ACA and programs like it is, can they make these approaches to engage beneficiaries be more about not narrow network and not getting the wrong services or restricted access to services or long waits, as you're seeing in many news stories these days, but can we find ways to support and encourage plans that get costs down the right way, by avoiding unnecessary costs, by engaging beneficiaries, by giving them high-quality care that does all of those innovative things that I was talking about earlier, and shares the savings with them, not just through the provider payment reforms. Thank you all very much for the opportunity to talk with you all today, and hope I provided some grounds for the later discussions. You got a lot of good stuff coming up. Thank you very much. Thank you. I think we have time for, one or two quick questions. I know I didn't solve all of the issues that we brought up today. Yeah.
Can you speak to the middle folks that are not qualifying for subsidies but can't afford the premiums and the health care, and then they're paying a penalty to get nothing? What do you see happening to those people?
Yeah, I think that's one of the many political challenges that isn't resolved. I mean, so far, there's been less, I think, blowback from these particular groups than many people were expecting. Maybe they're not that well organized. Maybe, we are talking about millions of people, but in the scheme of things, when we were implementing Part D, it was with like 35 million seniors at the same time. So, we heard about it. This is a bit less concentrated than that. And also these penalties are getting phased in over time. But I think that makes this more of a slow but persistent issue that's not going away. Especially if there are Republican successes in 2016, which there could well be, I do think there's a real chance that the mandate will be revisited. And first signs that you'll see that the political pressure from those groups who are facing penalties, haven't gotten anything that they see from the law, would be administrative steps to kind of relax the mandate. That's happened a little bit, so there are a lot of now exceptions to the mandate, and over time maybe those will get bigger or legislation might pass. But I would put that in the category of like unresolved issues that we're still debating through, and that's why the ACA benefits are not yet firmly established. I mean, I think we're going to do something about coverage for helping people like that with coverage, but whether it's through the ACA or through one of the Republican types of alternatives that I mentioned, or something in between, I think that's less settled.
Way back here on your right, Mark.
Hi, Dr. Bruce Carroll for UAW Retiree Trust here in Detroit. You touched on it briefly about oncology care. I think it was in your value-based slide, the breast cancer seemed to be cost-effective, but for the trust, and I'm sure for other players, oncology is a major cost, both in volume and looking at the price of the drugs that we pay for now and the pipeline. Can you comment on any of the government or CMS programs that might help payers get the costs of those agents under control?
Yeah, I think there are two kinds of programs, one that's more about oncology and one that's about oncology drug pricing in particular. For oncology, all the kinds of things I was talking about are there in spades. So oncologists get paid now in Medicare much more based on the volume and intensity of chemo that they provide than based on the time that they spend with the patient or the availability of clinicians in their office to treat a patient who's having an unexpected complication rather than sending them to the emergency room. And there are some clear examples of payment reforms in oncology that could help prevent that and get costs down. Oncology medical homes have saved money partly by encouraging more evidence-based use of chemotherapy, but it turns out there are even bigger savings possible, especially in the short term, just by making sure you're listening to what the patient really wants, making sure the patient understands what their treatment options are and have a care plan in place, and also making sure that there's some place that they can go if they have a complication besides the emergency room. So some of the oncology medical homes that have been set up under these new payment models will do things like, you typically call your doctor's office after hours. First thing you hear is, if this is a medical emergency, hang up and call 911. Well, this is kind of the opposite strategy. If this is a medical emergency, we will get you right to one of our doctors who will be available right now, even if it's after hours. And they have extended hours for their clinic, so if a patient is dehydrated or has a fever, they can come get treated there, maybe even get treated at home, which is much less expensive and much less bad from a safety standpoint than going to spend a long time in the emergency room if you're a weak patient undergoing chemotherapy. So those things really do save money. Now, more directly on the drug front, I talked about Part D pricing. Most oncology drugs are priced in Medicare Part B and are administered by physicians. And it's a very different world of pricing there, where basically in Medicare it's the ASP, and I think that drives a lot of what commercial payers do as well. The ASP is basically the sales price that the manufacturer names. So you get situations like in 2012, Sloan Kettering made news because there was a new drug that came on the market that seemed to have a very similar profile to Avastin, but was priced twice as high. And so they were, no, we're not going to pay twice the price, and the prices of both came down a little bit. That would never have happened in Medicare Part D if the drug was covered the same way. What the drug plans would have said was, okay, these drugs are equivalent. We're going to negotiate with both of them. We'll give a favored pricing to the one that's on we'll give favored formulary placement to the one that gives us the best pricing rate, and you can take the other one if you need it, but since there's no additional clinical benefit, you'd pay the whole additional price for that. And I guarantee in a situation like that, you get pricing that's like happened with Sovaldi, coming down when a second drug comes on the market, as opposed to just drugs of questionable value where there are alternatives available still being priced very high. There probably are further steps that could be taken around oncology drugs. I think and oncology costs, the ones that I just outlined, I think could have a fair amount of bipartisan support, though, and would make a real difference right now. Thank you guys very much for the opportunity to be here.